Thank you, Labs, for inviting me to present. My name is Behnaz Sarrami. I'm a pharmacogenomics medical science liaison at AltheaDx and a clinical research consultant at Washington University, where with our grants we help out older adults with their medications who are homebound, and also a host to the largest pharmacy podcast, which is Pharmacy Podcast Network. We talk a lot about genes and depending on their level of activity, what can happen, but I think it's best to highlight actual cases that occurred instead of just situational. So here's a story of a young boy whose name is Michael Adams Conroy. He was adopted at 3 years of age, but he was already having a lot of mental health problems as his mom was had abusive as a mother. He had a lot of emotional outbursts, so he was prescribed Prozac. For a while, he seemed to be doing better as his dose got increased from 5 milligram to 40 milligram. But unfortunately, he started having some symptoms like nausea, confusion, and seizure, and eventually, unfortunately, died. So toxicology reports found the cause of his death to be Prozac overdose at just age of 9. These types of stories are far too common, and it's important that we realize the genetic factors, especially when it comes to genes that have PGX indications, such as CYP2D6, which is the main enzyme for Prozac metabolism. Here's another case. David McIntyre was a 51-year-old husband who had stage 1 bile duct cancer with clear margin, not metastasized, and was successfully removed, and he was finally cancer-free. He had some precancerous cells, and so his oncologist prescribed him capecitabine. We know that capecitabine has a warning of not being taken if patient is deficient in DPD enzyme. So on his 7th day of chemotherapy, his symptoms started. He was having vomiting, diarrhea, mouth blisters, and rash on his face. Once the doctor realized that it could be due to his DPD enzyme deficiency, which is what is needed to break down the medication, otherwise it'll build up in the system, it was really too late. There's an antidote called Vistogard, but he had passed the 96-hour window of when the antidote could work. So he died an excruciatingly painful death after many strokes, aspirations, and his whole entire body was really decimated. Again, there are many stories like these, and actually 1 in 1,000 people have the genetic DPD enzyme deficiency that can be fatal. So imagine with a simple PGX cheek swab test, we can have prevented this tragedy. Mental illness is something we can't always see or do a blood test, but it's very common in the United States. 1 in every 5 adults age 18 and older have some kind of mental illness, which is roughly about 25% of the population. So now this does not include children under age of 18, but as we see, there are so many mental health problems in that age group as well. 1 in every 7 children aged under 18 have some mental health illness. The number of mental health, of course, keeps rising, unfortunately, especially with the COVID pandemic, and it's affecting everybody, especially the elderly. Depression and anxiety are highly prevalent, and although antidepressant medications are the 3rd most commonly prescribed drugs, the response rate, unfortunately, is very low. The other issue is older adults don't get treatment most of the time because there's a stigma of depression being a normal process of aging. So there's this big gap in getting therapy when medications are prescribed. They don't seem to be as effective and create the mental stability that is sometimes is key. So we want to get a person mentally stable soon so they can get better control of their life. Depression can be very debilitating for an individual and can decrease their quality of life, increase the amount of times a patient goes to the ER, which is 6 times more than the general public. It also increases healthcare utilization by up to 75%. I think to better understand how valuable pharmacogenomics is in a practice setting, it's best to go over what the current practice model looks like, or I call it standardized prescribing. I like to give this example of a psychiatric office with a new patient coming in for depression. What happens is the patient discusses their symptoms, their struggles, and the physician usually does an assessment of the situation. And based on the prescriber's preference, his or her prescribing habits, and the side effect profile of the drug, like the pharmacokinetics and pharmacodynamics, and what the patient is wanting to achieve, a medication is chosen based on the clinical judgment and clinical guidelines. So let's say the drug of choice was fluoxetine, since it's very commonly prescribed. A 30-day trial with 3 refills given, and the patient is told to try it for 3 months and come back and see how it works for reevaluation. So 3 months goes by, the patient sees no change, and then the doctor increases the dose, and patient sees a little bit of change, but then not enough to be satisfied. So the doctor adds on, let's say, bupropion XL for another 3 months and tells the patient to come back another 3 months. So when we count the total number of months, we realize it's been about 9 months that the patient has been struggling with mental illness. Some patients can't wait that long to be mentally stable, so sooner than later is better. So this is the current prescribing model, which is variable and is based on professional judgment, clinical judgment. It's mostly trial and error and and based on side effect profiles and the patient preference. But what happens is the patient experiences either no therapeutic benefit or side effects and becomes non-adherent to that medication. So, and up to 50% don't respond to their antidepressant on the first time trial. With pharmacogenomics testing, not only are we cutting back those months of getting to being mentally stable position and increasing adherence, there's also 52% decrease in hospital readmission, 42% reduction in ER visit, and 85% decrease in mortality, which is huge, and also saves a lot of healthcare costs as well. PGX is a tool, or pharmacogenomics for short, PGX for short, is a tool that we can use to guide therapy, just like blood pressure guidelines or diabetes guidelines. So here are some key enzyme players in mental health. This is not a complete list, but just a selected few. CYP2D6 is a big player, but there are other genes that play a role in mental health and have PGX indications, such as CYP2C19, 3A4, SLC6A4. I'm not going to go through all of them today, but wanted to touch on CYP2D6 mainly for today. And SLC6A4 is a key transporter that's a target of a lot of SSRIs. And it's said that people with short alleles are more prone to side effects and delayed response in SSRIs. So just to put it in perspective and kind of give a visual, this is a pathway of SSRIs, but it's specifically shows Prozac. I know that's a little busy slide, but if you see the asterisk on there, it represents the main key enzyme player for SSRIs such as Prozac. So on the left, you'll see the R enantiomer with a small portion that's unchanged and cleared out of the body. But on the right, you'll see the S enantiomer, which is mainly metabolized by 2D6, to the more potent metabolite of the S enantiomer. It's almost 20 times more potent. Other enzymes listed also play a part, like the 3A4, 2C19, and 3A5, but they only become important once you have chronic dosing. When the contribution of the 2D6 is diminished by inhibition through fluoxetine or norfluoxetine. So if the 2D6 enzyme is not active or a patient is a poor metabolizer, the conversion does not take place, and we have Prozac just accumulating on the left-hand side. Also, Prozac inhibits its own metabolism, which is why it has a long half-life. So you can imagine in the case of the little boy, he must have been a poor metabolizer, and accumulation must have been really huge. So 25% of all drugs, again, are metabolized by this enzyme CYP2D6, and being a poor metabolizer is more common than we think. 45% of Asians are poor metabolizer. It's a huge percentage. So I also have the ultrarapid metabolite percentage for the completion on here, which is on the other side of the spectrum. That also needs to be looked at. But it's not enough to just look at the enzyme activity of just one medication. We also need to look at drug-gene interaction as well. So this is where phenoconversion comes into play. So the definition is that there is a mismatch between an individual genotype-based prediction of a gene metabolism and its true capacity. So in other words, there's a mismatch between clinically observed phenotype and the phenotype you expect to see from a patient's genotype. This is a great example of why we don't want to interpret a PGX report in isolation. We want to look at both drug-drug interaction and drug-gene interaction. So you can be a normal metabolizer, but because you added an external factor, such as, let's say, smoking or even another medication, you phenoconvert to a poor metabolizer, let's say. And strong inhibitors, such as Prozac, can phenoconvert a patient to a poor metabolizer, and the opposite is true. Also, a strong inducer can turn a person into ultra-rapid metabolizer. So we call this the blind spot of pharmacogenomics, or what is better known as the Achilles heel. So it's not enough, again, to look at just one medication and see how a person is metabolizing it, but rather look at the drug-gene interaction as well. Again, the great example is CYP2D6, and I'm going to use Prozac to be consistent throughout my presentation. Prozac is a strong inhibitor of 2D6, and if we add tramadol, let's say for pain on there, which uses 2D6 to activate, we have just phenoconverted that individual. If the person was a normal metabolizer of 2D6, but adding tramadol made them a poor metabolizer of tramadol. So again, 25% of all drugs are metabolized by 2D6. So it's important, which is why this drug is really well studied. A lot of studies have been done about it. So here's an actual case study done on a 42-year-old female who came into her primary care with shoulder pain and was prescribed codeine with acetaminophen. She did well, and her pain was pretty much managed just fine. So this patient is a normal metabolizer of codeine. This chart is going to show you the affinity of a drug to an enzyme. So codeine has a weak affinity substrate for 2D6, which is indicated here as the 10%. Codeine is also an inactive medication needing the 2D6 to activate to morphine to have the pain relief. And we also see acetaminophen metabolized by CYP1A2, but there's no interaction there, so we don't really worry about it. So months later, there was a mass in her lungs that was found, and she needed some emotional support. So she started taking fluoxetine 10 milligrams every day, and she got increased to 20 milligrams every day over the next several weeks. Her pain started to increase, so her codeine dose was also increased. It went from 30 milligrams 4 times a day to 60 milligrams 4 times a day. So now we see that fluoxetine is a strong CYP2DC substrate, 40%, and extensively metabolized by that same enzyme. And as we saw earlier, it's also metabolized by 2C9, but that's just 5%. But since now there's another substrate with stronger affinity to 2D6, the metabolism of codeine is diminished. This is a great example of phenoconversion. The patient was a normal metabolizer of 2D6, but adding another medication made her a poor metabolizer. So a week later, she's taken to hospital to remove her mass on her lungs, and she's put on flecainide, 100 milligrams, given to add to her analgesic regimen due to her poor pain control. Within just 2 days, the patient had confusion, hallucination, and became aggressive. So what happened is that the drug-gene interaction was further aggravated. Flecainide is also a CYP2D6 substrate with strong affinity. And so what happened is both fluoxetine and flecainide compete for that same receptor. And the consequence is no pain relief. And also, since the dosage of flecainide is higher, the fluoxetine builds up, and you see side effects such as the one she was experiencing. So what ended up happening was codeine and flecainide was stopped, and the patient was only on morphine and fluoxetine. And based on this chart, you can see there's no competition between the two or any interaction. So all her adverse effects disappeared. This is a good example of, again, how pharmacogenomics testing in conjunction with patient's clinical history and being mindful of the drug-gene interaction is crucial in practice. And thank you for listening.